Hello, this is Jessica Hoyt from Winona State University, and today I will be sharing about 3 chapters. You know how I like to break things up into about 10-minute segments. So I'm going to be sharing 3 chapters about tracheostomy. I'm going to share my screen. Okie dokie. So tracheostomy is not to be confused with tracheotomy. Tracheotomy is the removal of the trachea. So an ostomy with an S is, no matter where, is a surgically placed opening to the outside of the body. So it's a common thing for somebody to refer to a hole in the neck underneath the trachea as a tracheotomy. That client most likely still has their trachea. So it is a tracheostomy, that little hole that goes in between that clavicular notch. That, like I said on the last slide, it is a surgically created stoma, aka opening, to establish a patent airway, bypass upper airway obstruction, facilitate secretion removal, permit long-term mechanical ventilation, and facilitate weaning from mechanical ventilation. So basically, and this is, a lot of this is in figure 23 or 26-3A. Tracheostomies are created to keep the client's airway open and to help that CO2/O2 gas exchange. They come into play for a variety of reasons. So for example, a client may have a long-term treatment plan that it was going to cause their face and neck to swell. So maybe they have some sort of face or laryngeal cancer that they're going to be getting radiation. They'll get a tracheotomy place or a tracheostomy place. I jinxed myself. A tracheostomy placed so that they can actually still do gas exchange in the lungs, even though they're getting swelling from their radiation up here. They may have some sort of chronic inflammation, which is creating copious, thick secretions, which is hard to expel through the mouth, which is what we normally do. Or they maybe are going to need to be on mechanical ventilation longer than 7 to 10 days. That's a care provider call. Current recommendations say, some say 7, some say 10, that you can be on mechanical ventilation. Or their vent weaning will take a longer period of time. So we'll put a tracheostomy into people who need longer term ventilation from an outside machine, a mechanical ventilation. There are a few different ways this happens. Sometimes it happens emergently. When it happens emergently, it's also called a cricothyrotomy. It can be done surgically in the OR. It can be done percutaneously at the bedside. My facility, we took everybody to OR. Other facilities do it percutaneously at the bedside. It's a facility by facility care provider call. So, advantages of a tracheostomy over an ET tube. They are easier to keep clean. There's less tubing. There's better oral and bronchial hygiene. The patient comfort increases a great deal, and there's less risk of long-term damage to the vocal cords. I've got a couple pictures to show you some of these advantages here on the next slide. So this picture right here is, this gentleman has a tracheostomy. And so just below his vocal cords, there is a hole, and there is a tiny little, it's usually about probably the length from your thumb joint to the tip of your finger, tube. It has a little cup on it. For those of you who have not seen an endotracheal tube, an endotracheal tube starts in the mouth, goes all the way past the trachea and the vocal cords. So it has a lot of the same parts as a tracheostomy tube, but it involves everything from the teeth all the way down into the trachea. So a tracheostomy tube involves far less body area, less of the overall nose to lung surfaces, And that lessens the likelihood of pressure injuries in the airway. Anytime we put a tube in, we have a likelihood of pressure injury. So if we've got a tube that goes from your teeth to your trachea, that's that much more area that we have that could possibly get pressure injury. The client with a tracheostomy can also close their mouth all the way. That prevents oral and nasopharyngeal infections. We need to be able to close our mouths to keep our biome in check. A lot of times people with ET tubes can end up with thrush, which is candidiasis, which is a fungal infection. The patient can also stay unsedated and alert with a trach if most of the time, which is not possible most of the time with an ET tube, because this endotracheal tube right through here is the gag reflex. And so people who have an ET tube have a really hard time just at the pure basic level of fight versus flight. There is something lodged in their airway and they will take it out without even realizing what's going on. The tracheostomy, we don't know, so this ET tube requires some sedation for that to be able to maintain comfort. Tracheostomy doesn't necessarily need to have that as much of an intervention. So here are the parts of a tracheostomy tube. And so we have this bit that sits outside here, right on that, right above that notch. And then there's complete with a flange. There's an outer cannula and a cuff. In addition, there's an inner cannula, and when they're inserting the tracheostomy tube, there's something called an obturator. An obturator, because these are very flexible tubes, this obturator stiffens up those tubes and makes it easier for the practitioner who's inserting it to insert that. And then the obturator gets taken out. Otherwise, we have an artificial airway that's blocked off with an obturator, which doesn't do anybody any good. So, excuse me, I'm gonna stop sharing. I'm gonna get a drink of water and I'm gonna come back with chapter 2 in just a minute.